Good morning.
Good morning, sir.
This is Neil Holton. I'm here interviewing Dr. Marco Carlin for the Anoka State Hospital Oral History Project. Thank you for coming in. This is April 4th, 2014. Let's start by learning a little bit about you, where you are from, your early life.
I'm a native of Minneapolis, born in 1924, and lived most of my life in Minneapolis. I'm a physician. I did go to undergraduate school at the University of Minnesota and to the medical school at University of Minnesota. Graduated in 1946. After which I did an internship in Chicago at Mercy Hospital. Following, in 1947, inducted into the Army as a physician, and spent 2 years in Japan in an Army of occupation. World War II had finished just prior to my going overseas. I then returned to Minneapolis and had a period of about 4 months before my fellowship at the Mayo Clinic in Rochester, Minnesota was to start. So I had 4 months with nothing much to do and found out that there was an opening at the Anoka State Hospital for a general physician, not a psychiatrist, to do general medical work for the patients. So I signed on and was there for a 4-month period until October of 1949, when I left to start my fellowship in Rochester. So my exposure at the Anoka State Mental Hospital was brief. It was about a 4-month period where I did live right on the grounds.
And in Rochester, what kind of fellowship did you have?
It was in internal medicine. It was a 3-year fellowship, and after completion of that, I returned to Minneapolis into private practice and spent 53 years in practice in Minneapolis until I retired at age 80 in 2004.
And you were doing internal medicine?
That is correct.
Would that be general internal medicine? Or?
Yes, it was general internal medicine. For 25 years, I practiced in a 2-man setup in downtown Minneapolis. The senior man passed away, and I then joined the Park Nicollet Clinic, and I spent 25 years with them till 2004 when I did retire.
Prior to working at Anoka State Hospital, did you have any knowledge of the place?
Not really. I had no knowledge of it at all. I can't remember who told me that there was an opening, that they were looking for a general practitioner, not a psychiatrist, but just to do the general medicine for the patients when they'd get a sore throat or pneumonia or a fracture, just to do general medicine. Mm-hmm. And I applied for that job and did spend the 4 months there.
And did you have any orientation to it? You just started working?
Just started working.
Okay. Do you think you were prepared for the job?
I think so, because I was given to understand that I was not to be involved in the psychiatric care or medications or treatments, and that my job was solely as a house doctor, so to speak, to take care of medical problems as they came up.
Was there a medical director?
Yes, the medical director, I forget his first name, but it was Miller was his last name. I forget his first name. And then there was a woman who was the assistant medical director. I forget her last name, but her first name was Gladys, but I forget her last name.
And is that the person that you related to?
I related to Dr. Miller primarily.
Could you describe him?
He was a huge man. I would say well over 300 pounds. So he was not very mobile, and he spent most of his time in the office in administrative work and did not get too involved in day-to-day patient care.
Mm-hmm. Do you know anything about his background?
I do not.
What other structure was there in the hospital administration that you knew about other than the medical director?
There was a social worker, I forget her name, and there was a nursing supervisor, and there were, as I recall, I was the only MD on the premises who was there full-time. There was a doctor practicing in Anoka. I remember his name, Dr. Ray Spurzum, as I recall, who was on call if there were some medical issues that developed, but he was not there full-time, and there would be days where he would not be called. So I was the only MD full-time on the premises.
And could you describe an average day? What did you do?
I lived right in one of the cottages. The physical setup was there was a circle of, I think, 7 or 8 cottages, they called separate buildings, each with about 100 patients. And there was a small apartment in the first floor of that where I lived, and my day was to just check with the nursing supervisor if there were any medical problems, somebody with fever or cough or sore throat. And as I say, I lived full-time there. I ate my meals, I slept there, and participated in the evening social events. And at that time, EST, electroshock therapy, was very prevalent, and the law required an MD to pull the trigger. So the nurses would get the patient set up. As I recall, 3 days a week they did do electric shock treatments, and the nurses would get patients all set up. As I recall, they would have 15 to 18 patients per session, and then it was my duty as an MD to pull the trigger on the machine.
And how do you think that worked?
At that time, this would be 1949. Those of you who recall that movie, One Flew Over the Cuckoo Nest, there was a patient, I forget the actor who's still alive, I think. So electric shock was very common, and it was on its way out as a frequent use and only for special purposes. But at that time, it was sort of the primary treatment. Medication for treating obstreperous or patients who were violent was just coming into prominence. The first medication, as I recall, was called Thorazine, and it was hard to get. It was just fairly new, so many times electric shock was the treatment of choice. I myself had very little training in psychiatry, and I particularly was not proud of my job of pulling the trigger on giving people electric shock, because in my experience it was used more, not more, but commonly, punitively. When the nurses would decide that somebody was acting up, it was used as a punishment rather than as a treatment. And I was never really proud of my job of pulling the trigger, but that was part of my job, and I was the only one with an MD on the premises, so it was my duty to, as I say, pull the trigger. Subsequent to that, it became less common in the years to come, and medication became more frequent in use for treatment than therapy. Electric shock is still commonly used, but more for severe depression that has not been successfully treated with medication.
And how do you think the patients viewed that?
They were fearful of it. They assumed that it was given as a punishment rather than as a treatment. And it was a rather crude, convulsive treatment, and there were side effects. Sometimes people with the convulsion that ensued did suffer some side effects, even fractures of, even though they were held down, there was some fractures that occurred, spinal fractures, and ultimately they started to use a medication which name I forget now, that was used in anesthesia to create muscle relaxation so that there wasn't such a violent convulsive episode. I forget the name of the medication. Perhaps you can refresh me.
I don't.
10 years removed from
Sure.
medical practice, and at age 90, memory is not as good as it used to be.
Was it phenobarbital?
No, it was a atropine derivative that caused a muscle relaxation, and it was used primarily in surgery to relax the patient during the anesthesia itself.
Scopolamine, maybe?
Again,
No.
I'll think of it on the way home,
Okay.
probably. It'd be too late to tell you about it.
How about these new medicines for psychiatric?
Not available at the time. You know,
Nothing?
actually, phenobarbital was used. A number of patients were epileptic and had seizures, so they were on phenobarbital. And as I say, the prime psychiatric medicine at that time to quiet people down was Thorazine, but it would just come in about that year, the same year, and was difficult to get, so they couldn't just use it for everybody. But all the medications that are available now, Prozac and so on, were not available. That all came later in the 70s and 80s. I'm talking about 1949, way back, so that treatment was, you could say, was in the dark ages.
And was Thorazine injectable or tablets?
There was an injectable, but there was also a tablet. But we dealt with people who refused to take medication too, so there was an injectable too.
And do you think it was effective?
It was the best that was available at the time. It is rarely used now. I haven't heard of any. As I say, I've been removed from clinical practice for 10 years now, but when I retired in 2004, it was rarely used because there was better stuff available, and it did still have a lot of effects of somnolence and so on.
Did you set up the treatment plans for the patients?
No. The treatment plan commonly was set up by Dr. Miller, and his associate was as I say, a woman, Gladys, whose last name I can't recall. So they would, patients were commonly referred by the court as committed, and there are very few people who got better enough to be discharged and sent home or to a halfway house. Most of them were there till they passed away. So once they were committed or voluntarily came, but most of them were committed either by family or by the court, and treatment plan was set up by the administrator and his assistant. They did have people coming to do part-time consultations, neurologists that would come from the university maybe once a week or once every 2 weeks, eye doctors that would come. This was at the end of World War II, so that there were a lot of people being trained at the university in specialty eye work, neurology, surgery, and they would come out when called for specialty reasons and administer to the patients. And as I said, there was a general practitioner in town named Ray Spurzum, who would be available if there was some acute situation that needed general medical work. But the psychiatric treatment in retrospect was pretty minimal. Not too many people recovered to the point of being discharged.
And the doctors from the university, were they residents or staff or both?
Primarily young fellows who had just come out of the Army, who were specialists in their field and were looking for an extra reason for income purposes. They were already certified specialists, but young fellows who had just come out of the Army.
Could you describe the intake and assessment of a person just arriving as a patient?
I basically was not involved in that. That was Dr. Miller and his assistant, who did prescribe the medicine, and they too would be the ones who decided who would get electric shock or not, but they commonly listened to the advice of the nurses. Were all, shall we say, long time experienced gals who, they were almost all women. I don't recall any male nurses there at all. They were long time experienced nurses who decided who should get a course of electric shock and who should get Thorazine when it was available. And so that many of the decisions were made by the nursing staff and not by the medical staff that was available.
Were there team meetings to come up with the plan, or?
Again, I was not involved in that because my job was to just walk around from cottage to cottage to see who needed some medical treatment for a sore throat or a fever or a cough or a fracture or whatever happened.
Do you think there were any safety concerns, either for the patients or the staff?
It was interesting that at that time, straitjackets and restraints was a common method of keeping somebody under control. Uh, it was not during my time, but I think the year afterwards, where that famous fire, when Luther Youngdahl was the governor of Minnesota, and he was instrumental in organizing a, what shall we say, a plan to do away with restraints and straitjackets and make treatment in the state hospitals more humane and more gentle. And the famous bonfire that they had in the square at Anoka Hospital to burn all the straitjackets and restraints. But that was subsequent to I was not there to see that. That came about a year or so later.
Okay. And did you know about the preparations for that, or?
No, I was not involved with that.
What kind of medical records were kept for the patients?
Again, I was not involved with there was a medical librarian who kept a file. There was a special room where they kept a file with the history of the patient, why they were there, who committed them, whether it was the court or the family or a voluntary admission. I was not involved in that record keeping. The only thing I did was, if I was treating somebody for pneumonia, I filled out a slip as to what the diagnosis was, what my findings were, what my program was in treatment, and that was sent to the medical records and put into their file. But I really never had access to the basic file as to why they were there and what their reasoning of the court or the family was for having them there. That was kept in the medical record department.
Did you have antibiotics?
Yes, this was in, as I say, 1949. So penicillin was available, both injectable and pills. Streptomycin was available for those who had, there were some tuberculous patients there, but there was not the wide range of 20 different antibiotics as we have now. We had a choice of 3 or 4 to use, but penicillin was very much available.
Do you know anything about the tuberculosis treatment that happened at Anoka?
I do not. All I know is that there were several patients who had TB, and there was a lung specialist from the university who came out, and by and large, they were given streptomycin as which was the treatment of choice at that time.
Did they do any of the collapsing of the lung surgically?
What was the word? It was not done there. There were some patients who had had it prior to coming to Anoka, but I was not involved in doing the actual treatments.
Okay. And how was the infectious aspect of TB handled?
There was as I recall, there weren't too many patients. It was, if they had TB to begin with before commitment, I don't think they were sent to Anoka. They were sent someplace else. This was for somebody who was diagnosed after treatment, after admission, and they were segregated in one of the cottages. So, but it was not a big issue. I forget where, I'm not sure where the main treatment center for tuberculosis was, but it was one of the different state hospitals.
Were you aware of any disagreements or disputes about treatment plans for patients?
Not really. I do know that disagreements commonly came up from the family. Uh, Family visits were common, but there were many patients who never saw anybody, never had any visits. But families that were concerned about treatment programs would bring their complaints or suggestions to Dr. Miller and his associate, and I was not involved in interviewing any families. I was aware that some families were upset and disagreed with treatment plans, especially some families objected to having electric shock for their loved ones.
Okay. Could you say something about the conditions in the cottages, how the patients spent their time, their living condition?
As I say, the nursing staff, I think, were all well trained, and many of them had been there for years, and I think they took care of the daily needs very well. As I recall, the facilities were clean. They were attended to very well. The food was excellent. I ate all my meals there too and gained weight actually because the meals were very fine. There were a lot of social interplay. They had programs, you know, the bingo games and meetings for the patients to talk in groups. I do recall evening social activities. It was common for church groups, synagogue groups, and very organizations to come out, especially on Friday night and Saturday night, to put on dances. They'd bring their own bands and so on. So there was always social activities, especially on weekends. And I recall going to the dances myself and dancing with the patients. And so they were kept busy for those who wanted. Depressed patients very commonly would just sit by a window and just look out, and it was an individual thing as to how much they wanted to participate in the activities going on.
Was there anything like occupational therapy?
There was some. Again, I was not particularly involved in that. They did have an occupational therapist, several on the grounds to set up activities. There were classes where they doing artwork, drawing pictures, needlework, and so on. But again, I was busy in my activities making the rounds, and I did not see that. But there was occupational therapy for those who they felt could do so and wanted to do so.
Was the farm running?
Yes, it was. Much of the produce, that was supplied at the kitchen for the meals was raised actually on the farm. The farm was right close by, and as I recall, there was a golf course right close by. Greenhaven, I think the name of the golf course was. I don't know if it still exists there or not, but I remember we just would cut through the farm. They did raise corn and wheat. I think some of it was sold in the farmer's market, but much of the produce, the tomatoes, cucumbers, vegetables, were actually used in the kitchen for the meals that were served. The meals were very good.
Maybe taking a little bit different tack here. Did you have any knowledge of the attitudes of people outside the hospital in the Anoka, city of Anoka or surrounding areas?
Not any direct context. Many of the people working, the nurses, the aides, the people in the maintenance lived right in Anoka. As I recall, it was one of the biggest, if not the biggest, employer in the town at the time. But I had no real contact other than the people that were living in Anoka and working at the hospital. I had no contact with people in Anoka who were not working at the hospital as to what their attitude was, whether there was any fear of patients escaping or doing any harm. And during my 4 months, or as I say, I was there only 4 months, there were no problems that I recall of anybody escaping and doing any harm or doing anything in the town itself that caused any alarm. Although the newspapers subsequently, as I recall, had some issues of people wandering in the town and creating some fear among the occupants who did not work at the hospital. But I had no particular personal knowledge of any of that.
Was there a security force?
Yes, there was, as I recall. You know, there were people who would act up and get violent, and if the nurses couldn't control it, they did have some muscle people who were on call. And you know, it was before the days of cell phones and so on, so that this was telephone availability, but they were called upon to restrain people. And as I said, at that time, straitjackets were a common way of controlling people. Another common way was hot baths. They would fill a tub with warm water, put the patient in the tub, and put a canvas restraint over the tub to hold him, and it was very effective. A good warm bath still is a good way to calm down, to not only physically but emotionally to relax people.
Would you say that your time here at Anoka stayed with you as you had your practice of internal medicine? Did you have an orientation toward psychiatry at all?
As during my fellowship at Mayo, it was a 3-year deal, and we were required to do a subspecialty of 6 months duration during that 3 years, either in pathology or in surgery, and I elected to do a 6-month stint in psychiatry and neurology. So it was a use of my knowledge of what I had seen, not really prescribing or doing anything other than the electric shock. And it was, what shall we say, a real awakening to see what was going on in the field of psychiatry in the late 40s and early 50s, where a lot of psychiatrists had come out of the Army and had set up different treatments with the medications that were available. Thorazine, as I said at that time, plus new ones were coming out. And then the less dependence on electric shock and less dependence on the surgical treatment of psychiatric things, lobotomy and so on, that had been practiced in the Army. And those of you who saw that movie about the cuckoo's nest saw some of the side effects of lobotomy. Lobotomy meaning surgical interruption of some of the pathways in the brain to try to calm people down, which is pretty much all passed by the boards and rarely done anymore.
And what else did you do in Rochester?
The rest of my 3 years was training in general internal medicine, diabetes, heart trouble, high blood pressure, and so on, things that I utilized in my practice once I left there.
Were the subspecialties of internal medicine as organized as they are now?
Not really. When I started practice, 1953 was when I opened my office. So that's, 6 years ago. There were a few subspecialists at primarily in academic institutions. So an internist, I remember there was no cardiologist. I did treatments for heart patients, liver biopsies, I did those, bone marrow biopsies, I did those. But after the 1980s, cardiologists, oncologists, cancer treatment, gastroenterologists were all trained specifically in those things, so that the general internist, like myself, became more of a general practitioner rather than a subspecialist doing those things that I had done. Spinal taps we did, and all of those things were taken away. In fact, I was rather, what shall we say, not upset, but missed doing those because I had been trained in doing those things, but those things were gradually taken over by the subspecialists who did those things and probably did them better than I did because they were doing it exclusively.
Did you and your colleagues feel that you could master the field of internal medicine pretty completely?
There were once you finished the training, the 3 years, you could set up your shingle and say you were a specialist in internal medicine, but to be certified as a specialist, you had to take an examination, both an oral examination and a written examination, and if you passed both of those, you could then be certified and hang up a shingle as a certified specialist in internal medicine. So yes, I felt qualified in doing those things that I was doing.
Could you say some more about your time in Japan?
I went into the Army right out of internship. This would be in 1947. I was assigned, I was unmarried, and I asked for overseas duty because I thought it would be interesting, and I was sent to Japan as part of a military government team. At that time, General MacArthur was what should I say, the head honcho in the Pacific area, and he had glorious plans about democratizing Japan, taking it away from the dictatorship to making it a democracy. And they set up what was called military government teams, a team of about 20 people, a doctor, a dentist, a school teacher, an economist, librarians, people trained in their particular field to be advisors and inspectors and educators to the Japanese equivalents in their particular area. I was assigned in the Kanagawa prefecture. Instead of states, they called them prefectures, and I think they had Instead of the 50 states we had in the United States, they had about 28 prefectures, and I was assigned to one in Yokohama, which was sort of a suburb of Tokyo, like Minneapolis, St. Paul. It was Tokyo and Yokohama, and I lived in Yokohama for 2 years. So my job was to go around and look at the different hospitals and health clinics in that area, both in Yokohama and in the suburbs surrounding, and talk to the administrators about how we did it in the United States, and set up more of a Western style medication and treatment, because it was common in Japanese hospitals for the families to move in and do the food preparation and bring the food and do some of the nursing care in some of the hospitals. They did have university hospitals too, which were more Western style, a Red Cross hospital as I recall, but it was rather primitive. And the military government teams that was our job to try to educate what Western, not just medicine, but dentistry, education, economics, and so on. So each team had its own function. And that was my job, in addition to doing the medical supply, treatment for the people in my team, because I was the only doctor involved in that particular team. It was a very educational, and I was very glad that I had that exposure. I was sort of a young pup just out of an internship, but it was very broadening, and I was unmarried and appreciated the time overseas to have that opportunity.
Did you operate with interpreters, or how did that work?
Yes. I had a personal interpreter that came along with me, a Japanese fellow who had been a physician in Japan, but had also spent some time in San Francisco, so he had a good knowledge of English as well as Japanese, and he went along with me on all my tours and was very instrumental in teaching me some Japanese too. It was a lot of fun to be able to go into a Japanese hospital and interview a patient in their own language.
And how do you think people reacted to Americans?
Japanese people, actually Oriental people at that time, were very submissive. You know, it was at the end of the war. They had been defeated, and even before that, they were very submissive, you know, with the attitude that you see in the movies. And I had the feeling that they agreed with everything you had to say, but went about their own way, doing their own things. They were very submissive. They were the vanquished, the defeated, so they knew their place, and they were very agreeable. And but I didn't see that our efforts were doing a heck of a lot.
Were you aware of the Atomic Bomb Commission that was operating at that time?
Well, we didn't know anything. I did visit Hiroshima and Nagasaki. I did go down there and spend a day or two visiting, so I saw the desolation, but I wasn't involved in any of the medical. There was a tremendous amount of irradiation sickness, leukemias, and people getting burns from the atomic radiation, but I was not involved in any of that treatment because Hiroshima and Nagasaki were several hundred miles away from Yokohama, where I was stationed. But I did have the opportunity to go down there. This would be 1949, so it was already a couple years after the devastation, and there were some efforts of reconstruction, but still much, much devastation.
Did you hear about James Neal, the geneticist who headed up the?
No, I was not. We were not involved in that at all. I assume he was studying irradiation sickness and people who were pregnant at the time, what their kids looked like if the mother had suffered from irradiation from the bomb. But I was not involved in any of that.
Maybe we could wrap up a little bit by, if you could give advice to advocates for the mentally ill, what would you advise now?
If someone in my family, thank God nobody has needed that, but was in need of some help for psychiatric reasons, depression, bipolar, I would say get involved with a good, sympathetic psychiatrist who is not overly aggressive and not in a big hurry to do aggressive treatment. There are many, many medications available for treatment of depression. In my practice, I would say the major issue that I encountered in my patients that needed help outside of what I could do for them was depression. And there were many medications that came aboard, Prozac and other medications that could be used that were effective. And some of the old-time psychiatrists were still trained in the use of electric shock, and I would advise my patients and families to use that as a last resort. It is still effective when depression fails to respond to the usual medications. I would say it's okay to use at that time. My experience and when I first started practice, there were books written. A lot of psychiatrists came out of the Army with patients who were having emotional problems. And the term let me think of the term, psychosomatic medicine became popular. Books written that were not popular in medical school when I went to school. But a lot of the psychiatrists felt that things like asthma, colitis, heart palpitations, ulcerative colitis were medications that were emotional and were amenable to psychiatric talking therapy and to psychiatric medicines. And there were a number of universities that set up departments of psychosomatic medicine. I recall for several years, the psychiatrists were saying, don't treat asthma with medications and send them to us. We can get them better with talk therapy. After several years, it became obvious that that was pie in the sky, and they would say, stop sending us, we can't help them, and they returned back to medical treatment. But the term psychosomatic medicine went through its phase. And there are still reasons for having a psychiatrist see somebody with asthma, but by and large they need medical treatment too. The same holds true for colitis and heart palpitations and other medical conditions.
Was there an equivalent of what now is called post-traumatic stress disorder?
That was a term that came out after the Vietnam War. There was still the term after World War I was shock, what was the word? It was shock, emotional shock, I forget the term. That was World War I. And then that sort of lost its popularity. In World War II, there was not much talk about emotional injuries suffered during the war. But during the Vietnam War is when post-traumatic stress syndrome became popular, and still is now. And it's a term used not only from war experiences, but people who've suffered, bad car accidents or bad emotional problems and divorce and so on, post-traumatic stress. And it's become very popular now because with veterans, with the compensation issue that is present in the Veterans Administration.
Do you think there was a similar syndrome after World War II, but just didn't get a label?
I think there was such, but it didn't get a label. I wish I could remember the term that was used after World War I, but there was nothing after World War II that had a label like that post-traumatic PTS, I guess. It's even gotten initials now.
Why do you think that was, that World War II didn't produce any knowledge about emotional damage?
I'm not sure. I really can't say.
Okay. What have we forgotten to talk about? Anything else?
I have, personal stories about living on the grounds, things that happened, things that I saw, and some things funny, some things rather pathetic. But that doesn't really, that's personal knowledge. It doesn't really add anything to the history of psychiatric medicine.
Well, maybe if you could share a couple examples of those stories.
I can recall several issues where you wonder why are they in the hospital to begin with. I remember, as I indicated, I lived in one of the cottages, and I had my own little apartment in part of the cottage, and I had one of the patients was assigned to tidy up my room and make the bed and clean it up. And I recall having a bottle of Jack Daniels sitting on my dresser, and I'd have a little canup before going to dinner at night, and I would notice for some reason the volume was decreasing faster than I was drinking it. So I had a suspicion that the maid that was assigned to me was nipping on the side. So I took a little pencil and made a little mark on the label to just try to figure out what was happening to it. And I noticed that it stopped dropping down, but I also started noticing that the shot didn't taste as good as it did. And she was smart enough to see what I had done and was watering it down to keep it even with my mark on the label. So I kept wondering, well, she's not as dumb as I thought she was. Another episode that was rather not alarming, but funny, but at the same time created a lot of havoc. And one of the other cottages, some guy, one of the patients, who was a schizophrenic, but I don't know how he managed to do it. He stayed up all night and wasn't detected by there was a nurse there throughout the night. She obviously was sleeping and wasn't watching, but he got into the linen closet and he took out a number of sheets and tore them into strips, and he tied them into, made a rope and tied these strips, and he stayed there all night in the bathroom. He'd feed in a couple feet of the strip of torn sheets into the toilet, flush the toilet so the strip would flush away, then he'd feed in another couple feet, and he did this all night long and put in hundreds of feet of sheets into the toilet, which went into the sewer and ultimately plugged up the sewer for the whole place, so that they had to call out the plumbing with heavy equipment to dig up the yard to get rid of all these sheets. It took a couple days till they could get the sewage system working again. So he was not as dumb as they thought he was. He knew what he was doing. And that was one of the more, funny, I should say, issues. But I remember going to some of the Saturday night dances, primarily they were church groups that would come out and they'd bring a 4 or 5 piece band of their own members, and they'd put on a dance, and there would be maybe 100, 150 of the patients that would come to the auditorium to dance with. And those of us, some of the nurses and myself, we would participate and dance with the patients. It was a lot of fun and some personal experience of my own. But as I say, I was not personally involved in any of the decisions about who should get what kind of treatment, other than, one other interesting thing that I remember, one of the patients, he was in his 40s, I believe, fell down and fractured his wrist. It was not a bad one. I put a plaster of Paris cast on it, and we'd come in the morning and the cast would be off, and we couldn't figure out what was going on. And I'd put on another cast, and the next morning the cast would be off again. And the night nurse finally figured out what was doing. And at night, when everybody was sleeping, he would go into the bathroom and he'd save a spoon from the kitchen, and he'd put his cast into the toilet to soften the plaster of Paris. With the spoon, he'd remove the cast, and the next morning the cast would be off. And we put on another cast, and the next day he'd do the same thing, till we finally convinced him that that was not a good thing to do for healing his fracture. So there were all kinds of interesting things that would go on.
So any final thoughts or additional?
My final thought is that the care of patients in the psychiatry has come a long way from the 1949s. It's more humane, it's more scientific, and it's probably more beneficial, because there are patients now who live to improve enough so that they are discharged and are able to go to either a halfway house into the community, or even to return to their own family. So there's been a lot of steps of improvement in the last, 70 years, I guess, since I was, 49, 50, that would be 50, 65 years since I was working out there. A lot of water over the dam and a lot of improvement.
Well, thank you for coming in today and sharing what you have about your experience at Anoka and your career too.
I wish I'd been there longer and acquired a little bit more knowledge, but it has given me a lot of time to reflect on what I did and what maybe I should have done that was better, but I was not in a position of making decisions. I was there to do my duty as a general practitioner. Thank you for having me. I hope it's shed some light for your the program that is being filmed for posterity for people to look at in years to come as to what actually happened there.
Well, thank you. You did a great job.
Thank you for having me.
You're welcome.